Well, it's great to be here tonight, and like Dr. Mullins said, we're passionate about this. Just a brief background about myself. I came straight out of residency and joined Kachina Family Practice. Best decision I ever made. In residency at the hospital I was at, we were on a NextGen product, so I've been through two transitions, two abstraction processes of going from paper to computer. So I have a sense of the pain that the previous speaker mentioned about going, but I really came in right as Kachina was going live with Practice Partner. And so we're going to talk a little bit about some of the things that we've learned and some of the successes that we've had, and we're going to demo the record in just a sec here. The first step any practice needs to make is getting rid of paper charts. And that was we wanted to get rid of that chart room as soon as we could. And so we had to develop a process by which we were going to do that. We called that our abstraction process. That was gleaning the pertinent data from the charts and getting that into the EHR and doing it quickly. So our system, I'll briefly describe it, ideally you do this in the first visit when the patient comes in on EHR. I was in some way blessed when I joined the practice that I had no patient volume. I was mainly seeing overseas patients for my other partners, and so I probably did a brunt of the work because I was seeing them for their URIs and quick visits, and so I would take advantage of that and say, let's go over your chart, and then you'd want to abstract. You get the medications. That's one of the first things you want is medication list. Add the allergies, and then get the past medical history. And then after that, what we would do is we'd slap a big A on the front of the chart, which means that chart had already been abstracted. I would pull out during that visit with the patient, and I'm doing this right with the patient in the room. I'd say, Mrs. Jones, let's sit down and look at your chart. And they're sitting side by side, and I'm pulling out the last mammogram, I'm pulling out the last colonoscopy. And that data we would then have that would become part of the permanent chart. And so we had a system, and once that chart and it doesn't really show you here, but if you look here, there's an A and there's a PC on that chart. A stands for abstract, P stands for PC. That was our internal way of communicating to all of our staff that chart was ready to go to the scanner, and we didn't want to see that chart again. And ideally, for most patients, once they came in one time in Practice Partner after we went live, their chart went away. And one thing you'll realize when you go to transition is old data quickly becomes irrelevant when you go to an EHR. There are certain things that we want to have access to, and that's why we were pulling out the last labs and so forth. And the rest of that record would then get scanned onto our hard drive that we could access from six clicks. Over the first year, we scanned 4,000 charts. We have currently about 9,000 active charts, and so we've, over 2 years, either had new patients or scanned in about that many. And the process of scanning the chart takes about 15 minutes of prep work, 15 minutes of scan time. And so if you pay one employee about $12 an hour, after 1 year, we spent about $24,000 in that process, having one full-time staff doing that. Second year, because the volume was down and we'd already done a lot of the work in the first year, we spent about $6,000 on our process. Now, just going back to what that quote was from that scanning company, we actually had two quotes, and this was the low quote of about $100,000. And so, bottom line, my recommendation for anyone who's trying to do this, find your own system, develop it. I wouldn't outsource it. You'll save a lot of money, and you'll have a lot more control and flexibility about the process. And it's really been a blessing to us to have these charts available. But that being said, again, we rarely have to turn back to them with an EHR. So bottom line, when you choose Practice Partner, as Dr. Mullins mentioned, you have a couple of different options. Some providers choose to stay and dictate. I don't think that makes sense personally because you're losing a lot of the power of the EHR if you continue it's kind of like doing what you've always done, but just doing it in a new way. I think if you're going to switch to an EHR, it makes sense to use a template, and we'll demonstrate why. Our goals for documentation were, one, we wanted to have a system where we'd have quality care, and I'll show you how the Practice Partner contributes to quality care. For me, the most important thing is I wanted to have rapid and accurate documentation. I wanted to leave at the end of the day and be done. I was tired of those days in residency where I'd spend an hour after clinic dictating to go home and miss a soccer game or miss something with the family because I had to stick around and do that. And I'll show you how since we've now been on Practice Partner, I average probably low 20s to mid 20s patients a day. I'm usually leaving the office within 5 to 10 minutes after my last patient, and I'm done. I don't go, even though I could document at home if I wanted to, because we have a system that allows us to document rapidly during the patient encounter. I leave it at the end of the day, and I love it. So that to me is the real power of Practice Partner. And our third goal is we wanted to get paid for what we are doing and optimize our billing and coding, and we'll show you how that works. So, by the way, our dictation cost went from $2,400 a month with 4 providers to 0 after we went live, because most of the 3 of us never dictated on Practice Partner. One doctor, like she mentioned, trailed about 3 months continuing doing occasional dictation, and once she realized that the templates were more efficient and accurate for her, she quickly switched over. We have about 240 different templates. In other words, when someone comes in, I see on the schedule syncope or passed out, I have a syncope template we can use that's going to guide through my documentation. We also have chronic disease-specific templates such as hypertension, diabetes, chronic kidney disease, you name it. And so those templates we can use depending on what the patient is coming in for.